Thank you very much. I'd like to pick up where Dr. Christensen left off because some of my providers don't feel like there's much of a partnership going on. And I would direct your attention specifically to the RAC program, where I'm advised that the American Hospital Association, based on self-reported data, indicates that nationally 74% of the appeals are being overturned in favor of the hospitals when this comes up. And apparently in my region, it's 78%. And it would seem to me, I mean, one of the problems that they're having is they feel like these independent contractors are taking the money and saying, wait a minute, we're not going to release this unless you go through the process, push it to the end, and then if you win in the end, you'll get your money. And so this is a real concern for them, because while we all want to get the bad guys, the hospitals, by and large, in my district are not the bad guys. They're the good guys. And I may not know of some exception to that rule, but I think they're all pretty good providers and are trying to do the best they can. And 78% being overturned on appeal indicates there's a problem in the system. Wouldn't you agree?
So, Mr. Griffith, I will say that we want to get it right, and we want to get it right for the good guys, and we want it to be as efficient as possible. The very high, we have heard some very high appeals successes, but it's only of a small fraction of total RAC determination. So when appealed, the overturn rate seems to be growing, but still only a very small fraction of total RAC determinations are being appealed in the first place. But having said that, we do want to get it right, and so we've put into place a number of checks to look back at what the guidance is that's going to the recovery auditors, what the number of documents that they're able to request. There are a lot of things that we're doing to make sure that the system is working, just as you said.
I would encourage you to do that. I would say, you know, I don't come from a medical background. I was a country lawyer, and most of the time when people lose, if it's close, they don't appeal, and I understand that. When they appeal, it means that they really think they've been treated wrongly. That being said, in my profession, if you had a 78% turnover rate, you'd have a judge being removed. And that's what I'm looking at is that, you know, in this case, if we can't get it straightened out, we may have to look at a different system, because that's not fair to the medical providers. And so I do appreciate that. Also, one of the other complaints they have that ought to be simple to fix is when they're denied, they get a letter. But when they win or they get it overturned, they don't get a letter. So all of a sudden, a check comes in, and they have to track down, why did we get this check? Sure would be nice if there was a tracking number or a letter that came with that said, we've decided you were right, and here's your check. Can you fix that?
I will make every effort to look into that, sir. I've initiated a number of actions to, shall we say, improve our communications, and I'll put this on the list. Thank you.
Sir, and if I might add.
Yes, ma'am.
There has been a change in the design of the RAC program so that if the provider wins on appeal, the RAC doesn't get to keep the contingency payment. And that's a change from earlier. And I'd also add that we have been asked to look into, and we have work underway now, that looks at what's happening in post-payment review and the coordination of those contractors that are doing that and whether there's duplication, and also to look at the communications that they're issuing. So we'll have something to say on that later this year.
Well, I really appreciate that and hope that you all will continue to work to make this an easier process for the providers that are just trying to do what they do, and that is to help heal people. That being said, let me shift gears slightly and just ask if there isn't more you can do in the private sector. In our area, we have, I represent Southwest Virginia, which includes a big chunk of Appalachia, and we've had a problem with abusive drug usage. And some of the private companies are doing things that actually work to stop that, such as they have one they call the lock-in program, where if somebody's abusing, they don't stop giving them drugs if they need help, but they don't let them go from doctor to doctor. They're locked in. Can we do things like that to try to look and see what the private sector is doing, like the lock-in program? And there are others that I have here, but my time's running out.
We have been looking at what the options are, because we agree that where there are problems such as the ones that you mentioned, we should look to do the most we can. I will say that the constraints that we have certain rules that do or do not apply in the Medicare program, we may have different options in terms of what we can pursue. I don't know if you've looked at this or not.
Well, and let me just say
We have
this.
actually looked at it, and we have made recommendations that CMS consider that, and I think their response back to us has been that they believe there are some legal restrictions.
Well, let's just say you're at the right place to get those legal restrictions changed, and if you need something that helps catch the bad guys but makes it easier on the healthcare providers, we'd be glad to oblige.